Hello, everyone. I am Basil Tarab. I'm a Master in Healthcare Administration, and I have three special guests with me today that I will ask them to introduce themselves. Michael,
Hi, good morning. Yeah, my name is Mike Drusano. I'm a family medicine physician based out of Central California. My work with SAMS, I worked in Greece back in 2016. I was working with other SAMS member, Lena, in developing the internal medicine residency program in Idlib. Those efforts kind of had to be called off temporarily just because of issues that are ongoing there. And most recently, I presented at the national conference in this past February with SAMS.
well, thank you for being with us today. Dr. Abbara.
Thank you. So my name is Aula Abbara. I'm an infectious diseases and acute medicine physician in the UK. And I've been volunteering with SAMS probably since about 2012, 2013, initially in Jordan, then Turkey, and then in Greece. I'm also the research lead for the Syrian American Medical Society.
Well, thank you for being with us today. Afsana.
Hello, hi. I am Afsana Safa. I'm also a family medicine physician based in London, in central London in Westminster. And I work in healthcare management as well, particularly around cancer. In regards to SAMS, I was one of the first medical coordinators for the European response of SAMS in Greece in 2016. And I've also worked in Bangladesh in 2018 along with SAMS as well.
Thank you for being with us today. So let me start by asking you, how did this pandemic change your work? Michael, could you speak a little bit about that?
Oh, certainly. I mean, it's actually affected family medicine profoundly. The clinic system that I'm currently working in, it's virtually all telemedicine. We've converted all appointments over. Patients are only allowed in if it's deemed by the physician to be essential, that a physical exam, seeing them in person is essential, in order to establish a diagnosis. And in that instance, before they come in, they are actually screened for COVID-19, temperature and symptom-wise. I think the only exception is actually well-child visits, which is just falling in line with American Academy of Pediatricians recommendations. We're still bring children in for well-child checks for vaccines or whatnot, but both they and only a single accompanying guardian must both screen negative for COVID-19 before being allowed inside. And I think that in particular was just a lesson learned. I think after the Ebola epidemic, we're in the 3 countries of West Africa that were affected during and after the Ebola epidemic. There was an explosion in vaccine preventable illnesses in the region, measles in particular. So, I mean, I think that's why the AAP came up with those particular guidelines.
It looks like your work changed a lot. So Afsana, you have the same specialty, but you work in a completely different healthcare system. Can you talk about that? How did your work change?
Of course. So in the UK, we have a universal healthcare system. We have universal access to our patient records, particularly across Westminster. And in family medicine, we cover everything from internal medicine to gynecology, pediatrics, psychiatry, the whole range that we cover in primary care. Similar to what Mike was saying, we've also changed completely over to remote consultations. So lots of video, but also lots of telephone, but lots of video consultations using people's smartphones. So we can just talk to them as I'm talking to everyone now, which is a great way to consult. And we screen people for coming into the surgery as and when they need to. We also look after COVID patients too. So obviously very sick patients will go to hospital, but those with kind of mild or moderate severity symptoms are looked after by us in primary care. And how that works is we've set up a completely separate site, which we called our COVID hot hub. And for us, our one is in Soho. And we have patients come there if the GP is worried, if the primary care physician is worried. They refer them to us. We have a patient transport system using local London black cabs that goes to pick up the patient, brings them to us, and then we see them there. What we know around COVID-19 is that it affects the breathing and it affects the oxygen levels in the blood. And also that people can deteriorate without even having that many symptoms. It can be quite silent and quite quick. And so because of that, we've developed quite a model, a new way of monitoring patients, where we give the patient an oxygen saturation probe that they take home with them, or we deliver it to their house. And then they have an app on which 3 times a day they put their oxygen levels, their symptoms, how they're feeling, heart rate, temperature. And we have a dashboard in our clinic, and we monitor them through the dashboard, so we can constantly keep an eye on all the patients with COVID-19. Within the UK, also within primary care, we visit patients at home, which we've always done, and it's no change now. We still visit them at home if they need to, and if they've got COVID-19, also with careful protection as much as we can, and we still do visit patients at home.
Well, Afsana, are those changes limited to your practice, or is it all over the UK? You mentioned a lot of changes.
Yeah, a huge number. And this has been across the UK. The digital changes that we've gone through have been huge. And I think one of the things that has facilitated that is the fact that we are a universal healthcare system. So within Westminster, actually for Northwest London, which has a population of 2.5 million, we're able to share the records with the hospitals amongst each other. In Westminster, we have a population of 250,000 people. And now I can see the records of all those people there. And I can look after patients from different surgeries because workforce are affected. I've had symptoms of COVID, lots of my colleagues have, and if we're off work, we need to still be able to provide a service. So we've facilitated remote working for staff, as well as joined up working across the system. So it means that we can do a whole lot more things in one go, and it's made us much more efficient.
Oh, wonderful. So Michael, I'm going to go back to you. Do you think such changes could be applied to the United States? And I know our healthcare system is built completely differently. Can you talk a little bit about that?
I think, yes, we possibly could. I think that from what I know about the NHS is that, yes, like there's a lot of home delivery services that are available. So I do know that, for instance, in what I've been told is, and maybe it might differ across the UK, but in the instance of influenza, you think you have influenza, you call this special number if you kind of meet inclusion criteria. Someone actually goes to your house, delivers oseltamivir. They'll be able to monitor you that way. They want to make sure that you don't potentially bring influenza into the clinic, infecting other patients, infecting staff. I do think that, yes, it would probably be able to be done in the micro level within particular smaller healthcare systems. It has not been, that type of delivery has not been experimented yet with, as far as I know, within the Indian Health Service, IHS, and it's the special health service provided by the US government for the Native American Indian population. But I think as what's very much come to light, or we've been very much reminded of in recent weeks, that Americans very much are big on privacy. And I also think too, yes, if you do look at the US history with some of the justified mistrust of the government. So I do think that while in theory it could be implemented, and I think there are definite benefits to it, how successful, how receptive the patient population would be, it would be very difficult to say.
I see. Well, thank you for the explanation. So, Aula, you are an infectious disease specialist, and you are on huge demand now, for, everywhere you go in every healthcare system. I would imagine that, your work has changed dramatically due to the pandemic. Can you talk a little bit about this? Do you see mainly COVID patients now, or how is your work life now?
Yeah, I think you hit the nail on the head. So the majority of patients that we see are either confirmed COVID-19 patients or suspected. And so there's been a shift in the way that we think about patients and approach healthcare and patients. And it's become very normal for us in hospitals in the UK to discuss patients in terms of whether they can go to what we call a red ward, so highly suspected or confirmed of COVID, versus a green ward, so very low risk or known negative COVID-19 patients. And that's been important across the board to make sure that our patients who are low risk and have come in with other conditions stay safe in hospital. And I think there's been a change in the way we run our hospitals. So as many of you will know, for us in the UK, it was in about March where a lot of the surgical specialties only did emergency care. So all routine care was stopped. And all extra meetings, for example, some of our departmental meetings, our grand rounds, were either stopped or done remotely, and we're slowly reintroducing those. The other biggest shift, which I think is a positive thing to start now and continue, is the shift to telemedicine for the select number of patients that you can have those consultations remotely with. And of course, there can be huge benefits for patients, particularly in London, who may be frail, who may be susceptible to infection, for them to be able to have a conversation with their physician in the safety of their own home. We do, of course, call patients in to a safe area of the hospital should they need to be assessed and for us to see them. And then the other big thing that really has changed is the way we are running our hospitals, and that's everything from the PPE that we use, our interaction with our colleagues, and also just making sure that our healthcare staff remain safe. So as Dr. Afsana said, there has been quite a high burden on healthcare workers, and it's really important for us as infection physicians or people engaged with infection prevention and control to make sure that our patients, but also our staff particularly, are safe. And of course that they feel safe and that they feel that they can ask questions about things that are directly relevant to them.
I see. And Aula, now we see that, the recommendations has been changing very quickly. And, during this pandemic, the information surge is really as big as the viral surge. And some people are referring to the pandemic as infodemic now. What, today is May 12th. And what is the most updated information of, or protocols that you have for treatment, for COVID-19?
So this is something that's really important, and actually, particularly in March, where some of our guidelines were changing almost on a daily basis as new information was coming. Part of my job as an infection physician was to stay as up to date as possible and ensure that information is transmitted to other frontline healthcare workers. In terms of the most updated, what I can say that's positive about this pandemic is just how quickly, for example, the virus was sequenced, how quickly the PCR testing was rolled out. Of course, there was issues with capacity in different hospitals, and initially it was all very centralized, but of course that diversified very quickly. And then in terms of some of the trials that have been set up, so in the UK, it's our policy not just to provide different treatments. Any patient require treatment, for example, with antivirals like remdesivir, or some of the anti-IL-6 medications that are in use should be considered for a trial. And that's been a really good way to ensure patients receive some of these experimental medical products in a very safe way. So the very latest in terms of treatment is our understanding of, I suppose, the two phases of the illness. So very early on, you'd see the viremic phase, and then some patients will get better after that and will continue to get better. But there are a proportion of patients that have what we call cytokine release syndrome, so an overwhelming immune response that causes a second rapid deterioration. And so there is a great deal that we know about the virus and the condition, and we're learning it almost day by day. But there's also a great deal for us to understand in terms of what medicine for what patient or what time is going to make the biggest difference.
I see. And Afsana, you work in the same healthcare system. What is the source of the information that you get your updates from? Is it, do you get like information distributed by the government, or do you have to seek this information, or do you have to like seek consultations from your infectious disease colleagues? How do you do that?
Yeah, so there's a number of ways in which we've had to change the way we receive information. I mean, previously you get your updates slowly and you go to your learning. Now, again, as Aula said, it's almost daily, weekly updates. And it's not just the infectious disease around COVID-19, but COVID-19 and respiratory diseases, COVID-19 and cardiac conditions, COVID-19 in pediatrics and psychiatry, and we're having updates continuously. We usually get them via webinar with our hospital colleagues, much in the same way as we're talking now. We get paper updates, obviously, emailed through to us with the latest information, both from national teams, but also from our local hospital teams as well. And it is a case of, keeping up to date as much as possible. Something else we've instituted locally is because every single condition is changing now, particularly because we can't see patients like how we used to, we have to treat them in a different way, as well as making decisions on which patients we see, if they've got COVID or not. In our clinics, every single patient we bring in, we discuss with our colleagues. So we meet in a huddle 3-4 times a day to go through every patient we've talked to and discussed, to make sure that we're all doing the absolute best that we can for every patient. And your decision making is much stronger when you approach it as a team of doctors, as opposed to just one doctor at a time. And we found that really helpful.
I see. And Michael, can you talk a little bit about the methods of communication in the healthcare system in the United States regarding this?
Well, I think the decisions, at least I think to like kind of follow Afsana, is the decisions as to whether or not the patient needs to be brought in to be seen is actually just made by the individual doctor. And it might just be a reflection of just like the inherent individualistic nature of American culture. But it has changed the way in which we've communicated. I know there's been relaxation of HIPAA, which is the privacy law in the United States, which does allow for physicians actually to work from home, communicate with patients through other methods. I think before, like HIPAA was incredibly strict. And I think if you were to be doing any type of telemedicine, there had to be a bunch of different encryption requirements, even like through the telephone. But I think like those were relaxed. Me personally, I was actually in Colombia before there was the shutdown. I had to make my way back to California. And once I did so, I was just told that I couldn't enter the clinic because I had traveled abroad. But what they were able to do was actually bring me a laptop to the place where I was staying. And I was actually able to just communicate with patients through my own personal cell phone. And actually access all records just using the Wi-Fi in the extended stay hotel where I'm staying at. And so, yeah, I think it has kind of like loosened things up. It's made it a little bit better in order to connect with patients, if that answers your question. I think too, maybe just touching back on what we discussed earlier, maybe there's going to be different expectations as to how we communicate with patients from now on. I worked, before I was working this particular locums job, I was working for a very large health system based on the US West Coast. They relied quite a bit on telemedicine. I think for certain things, yeah, it is actually very useful. It's very efficient. For instance, if the patient is just complaining of a simple problem like insomnia, most of that is actually the history. You don't really need a physical exam for plain ordinary insomnia. And so that was able to streamline things. But however, I do think that there's some dangers, there's some pitfalls. Patients would call the call center, the patient would be triaged. And for instance, we had one patient who called, who was febrile, who had a temperature of 104, which I think in centigrade is about like 40, 41 centigrade. But the patient was on an immunomodulator, CellCept, which meant that, yes, like that was sepsis until proven otherwise. But instead of being directed to the nearest emergency room, instead the patient was given a telemedicine appointment with me 3 hours after they had called the call center. Luckily, by the time that I had called the patient, yes, the patient was still alive, and I was able to give appropriate direction to them. So, I would say that while I think that maybe these recent changes will have beneficial impacts like on health systems worldwide, we do very much have to be aware of the pitfalls.
I see. And Michael, you mentioned the term patients' expectations, and this is big. So now when patients come to see you, what kind of feelings do you think they have? Are they appreciative that you are implying all those measures and these new things that they are seeing that they didn't used to see it? Or do you feel there's a level of frustration? What's your general, I know this is very individual, but generally speaking, what is your general feeling about this?
I think it also just depends on where you go and what your patient population is. I think the patient population with which I'm working right now, serving, they're very much, I think, underserved. And I think, the particular clinic system that I'm in does have like some difficulty just given its geographic location of like retaining physicians. So I think just as a whole, the patient population does tend to be a bit more grateful. But I think also simultaneously, they tend to be more understanding. They're very much aware of what is going on right now. I think a lot of them, they don't want to leave their homes. They don't want to come to a clinic unless absolutely necessary. And they have expressed like a good amount of gratitude, just saying like, thank you for helping me with this issue just through the phone, as opposed to having to come in or go to a hospital emergency room. I think a lot of the stuff that we've also have been dealing with over the telephone, it's been just regular, ordinary, run-of-the-mill stuff that we see in outpatient clinics. But simultaneously, because the symptoms of COVID-19 tend to be just so broad, patients understandably are very worried as to whether or not they have it. And I think it does, assuage a lot of their concerns, their fears, at least just to be told over the telephone, like, no, like this really doesn't like sound like COVID-19. Like I do think that like that's very much low in our suspicions. Versus, I don't know, I think if my prior position back up towards the Bay Area in Northern California, stuff that I'm hearing from colleagues there though, that I'm still in contact with is, I think there is a lot more frustration that, patients cannot be seen in the way that they want to be seen. But then I think also at the same time, healthcare services there are a lot more accessible.
I see. And Afsana, would you say, the patients in the UK are behaving similarly? It's a similar, but also a different culture in the same time.
Yeah, absolutely. I think obviously the culture here is that healthcare is free, so people can access for anything, and they can access us quite easily, and that has reduced. But I think we have certainly it's still in our honeymoon period. People are very happy and thankful for the care that we're able to give. We are, with regards to COVID-19, obviously we are following them up, some of them using the app and remote monitoring, others with daily calls, and they can call us anytime to discuss their symptoms. What we're finding, however, is as Mike said, is that people are scared. They're scared to access hospitals. They're scared to access general practice in our clinics. And we're really worried about that. We've seen the number of referrals for, say, things like cancer or heart disease have completely dropped. And those conditions haven't gone away. They're still out there. And we're really concerned that people, because of their fear, are not coming to see us. So we're actually going the other way. And we're putting messages out there now, perhaps on social media or through other routes, to remind people, especially children as well, so parents are worried for their kids, to say, come and see us, we are here. Yes, it might be telephone or video to begin with, but if you need to be seen, you will be seen. And we're slowly approaching the recovery phase now in the United Kingdom and in London. So we're turning services back on. So for example, at the beginning, some diagnostics were turned off that weren't immediately necessary. Those are slowly being turned back on now. So we're trying to get back to business as usual. We just want our patients to come and see us.
I see. So what I'm gathering from what you are saying is that people are complying with the recommendations that are coming to them from the government. So that leads me to my next question to Aula. Aula, people are staying home, but this is going for a long time, and people, frustration is building up in the population. But as an infectious disease physician, what do you think about this recommendations? Is it really working? Are we really flattening the curve? Is it really helping you as a physician?
So the answer is very much yes. We are basing our information about this on the modelling that's been done by various academic institutions. And what they did was model the exponential growth of the COVID-19 pandemic, and then put in a kind of experimental values as to what would happen with lockdown measures, people self-isolating, people being put in quarantine, for example, what social distancing measures, the closure of schools and other public institutions, and how that could affect the number of cases that we see. And actually, so we went into lockdown in the third week of March, And my concern would be that if we didn't at that point, that we would be seeing far greater numbers of patients come in as inpatients, but also sadly into the intensive care unit than we have done otherwise. So I would say very much as a public health measure, it's been really, really important to enforce these things. As many of you will know, this week in the UK, we're waiting for further guidance as to the next steps and which of our institutions are going to open, how and when. And for us, this is really important because in hospital, we're going to move from a workload which is predominantly COVID-19 to one which is very mixed. And I think it's that phase which is going to be very concerning, because we need to make sure that we have sufficient capacity for our patients who will continue to come in with COVID, but of course for those patients who come in with other conditions. And like Afi and Mike have said, we are encouraging our patients to come in. So for us in infectious diseases, we've been very concerned that we've not seen as many patients with septicemia, for example, or kidney infections or urine infections or other pneumonias, for example. And we don't think that these cases have gone down. We are worried that they're not presenting to us, but remaining in the community. And so we are encouraging people to present to A&E because we do have capacity to see them.
I see. So it looks like, flattening the curve is working for you. But what's the final answer? Is it that we find a vaccine? Is it that we find a treatment? Where do we stand with those measures? Can you share the most updated information about this?
I think there remain a lot of unknowns. The suggestion is never be fully safe till we have an effective vaccine. And I'd be surprised if it's not months, if not longer, before we see a workable vaccine that's effective, but also remembering that it needs to be in sufficient quantities to reach all over the world. So not just those of us who are in high-income countries who, let's face it, are very privileged. We've got relatively good health systems. We can socially distance, we can self-isolate, but those people who are very vulnerable, so people in refugee camps, such as in the Rohingya refugee camps, where the density is 40,000 per square kilometre, those who are sadly in refugee camps across the Middle East, and that includes Syrians who've been displaced from their homes.
I see. So, and what about the treatments? There's so many treatments, none of it I think is approved. There are several trials. What have you been doing for this?
So in terms of treatments, I would say watch this space, because I don't think that we should be using experimental treatments without good evidence that they're going to be effective, because remembering there are treatments that are being used. So hydroxychloroquine and azithromycin is an example. And I was very concerned to read that actually some factories in Syria are rolling out production, when actually the side effects of these are very significant. So combining those two medications can cause arrhythmias and can cause death in patients who might otherwise have pulled through from their COVID-19. So with all these treatments, I do think we need to be very careful, and I have yet to see good evidence for these treatments to say this is the one to use in this patient at this time. I am hopeful for some of the antivirals that are being used, and I'm also very hopeful for some of the immunomodulators, so the anti-IL-1 and anti-IL-6 medications that are being used in that second phase, so in the cytokine release phase. But I would, as a clinician, be duty-bound to wait until we have good evidence that the benefit of these medications, alongside with clear guidance as to which patient groups we should be using them, and also more evidence as to what the long-term consequences of some of these medications are, would be before I start prescribing them to my patients outside of either compassionate use or trials that are being run in the UK and internationally.
I see. And I would imagine as time goes by, we learn more about this virus. It's a novel virus, so it's new, but it still will behave as a virus by the end of the day. So speaking of that, and I know there's a lot of unknown, but do you think we would have other waves of it? And if yes, when do we expect that? Is it going to be around the same time of the regular influenza that everybody gets, or do we have any expectations or any guesses?
I have to say, I don't think we can fully answer that. And different countries are going to be at different times in their epidemiological trends. I would be unsurprised if there was premature lifting of lockdown measures and social isolation measures, that we wouldn't see a second peak. And if you remember back to the early 1900s flu pandemic, the second wave, when people came out and were no longer isolating at home, there was an even higher mortality than in that very first wave. And I think all of these needs to be managed very carefully by our public health institutions. And also we need our public to continue to be vigilant as to the risk, and also not consider themselves to be without risk, even when we start going back to schools and open our public institutions.
I see. So Afsana, you know, there are lessons that we are learning from this pandemic, and you know, as we expect that possibly there will be other waves, you know, coming. What are some of the lessons that we have learned, and you think that we should apply if another wave hits us? And what are the things, or some of the things that we should avoid be doing when we get hit by a second wave?
Yeah, so I think, I mean, thinking about the second wave is very much what we're planning for now, especially as activity is a bit low as we're coming out of the first wave, and we need to be really vigilant for the second wave. Firstly, there's the public messaging and making sure that the public are aware of their part they need to play, not just in social distancing and being sensible, but also aware of the symptoms and to self-isolate and to call for help. For our systems, we're far more aware now of how the virus presents, and you know, hot zoning, so red and green zoning our healthcare systems. So whether it's primary care, we have our hubs now running in the community. We're going to be able to pick up patients a lot earlier than within the first wave to get them into hospitals quicker, so that the right patients can get the right treatment and hopefully improve our survival from that point of view. Obviously, it's less firefighting and much more of a managed approach, and I think that's what we need to think. And obviously, as Aula has said, we're waiting for the results of trials to come out to know, in terms of that first phase in the community or the second phase in the hospitals, how our treatments will change.
I see. Michael, you are in California, so I would imagine, you know, there are different lessons that the United States could learn from this pandemic, other, you know, different from the UK. What do you think the United States, or specifically wave?
Pardon, could you repeat the question?
Yes. So you know, Afsana gave us, you know, a good understanding, or some answers about what she thinks needs to be happening when a second wave hits us. You work in a completely different healthcare system.
Right.
Are the lessons that we learned from the first wave, you know, in the UK, could be also applied in California, or each place has their own specific measures that they need to apply? Is it, you know, one size fits all, or no, there's something specific to California or the United States in general?
I apologize. You were breaking up when you were asking the question. Could you just repeat it again? I know.
Yeah. No, it's fine. It's fine. So, Michael, do you think California has specific lessons to learn from when we get hit by a second wave? Are there special things that we should avoid doing, or what did we learn from the first wave, specifically in California?
I think, you know, there's the expression in the United States, however goes California, so goes the rest of the country. And I have to confess, you know, I think that leadership, in particular in the Bay Area of California, the zone like San Francisco, Oakland, San Jose, they were the first area of the country to do a complete shelter-in-place order. They decided that they were not going to mess around with it. And consequently, yes, the curve in the Bay Area has been considerably flatter than the entire United States. And I think kind of like pulled California in the right direction. It seemed as if like maybe in the week afterwards, other municipalities within California decided to do shelter-in-place orders. And then so went the entire state shortly thereafter. So by the middle of March, the entire state of California was shut down. And so I think consequently, yeah, like I said, we are seeing like a flatter curve in California for the rest of the country. So I think that Maybe what we can learn from California experience is when it does seem as if cases are starting to ramp back up, the appropriate measure is to just, yes, do a complete shutdown, lockdown as quickly as possible. And really, like, only essential businesses should be, and services should be remaining open until we get the all clear.
And Michael, how are you doing in California on PPEs?
I can only really attest to my clinic. So far, our clinic, we've, I think, had an appropriate quantity. However, if we do feel as if a patient does need to be tested, we're very judicious about the use. So, all patients that do need to be tested for COVID-19 come in at 3 o'clock, or rather drive to the clinic's parking lot at 3 p.m. They let us know the particular car that they're going to be driving, and then we go out there in PPE to test ourselves. We don't bring them inside, as opposed to kind of like a rolling testing. When they call, then they come over right away and we test them. We would end up going through a lot more. So we are going through, at least as a clinic system, measures to avoid using more PPE than is necessary. I personally have not had anybody yet, but if there was any evidence that they needed more urgent care, we would say just skip the testing here in clinic, go to the emergency room. And that pretty much is like shortness of breath. That also being said, I think maybe just naturally in times of high anxiety, patients do need to be educated on what exactly shortness of breath is, because there's some people complaining of shortness of breath, but they're speaking in a very long-winded fashion, much like I'm speaking right now. So, kind of like reassuring them, like, no, I don't really think you're short of breath. Like, you're speaking to me in full sentences. That I think just help triage patients. That also does help relieve some of the anxiety.
I see. And Afsana, can you talk to us a little bit about PPEs in the UK? Are you short? I mean, there's a global shortage, but what's your situation in the UK?
Yeah, there is a global shortage, isn't there? And you hear from stories all around the world from healthcare colleagues who are struggling. In the UK, we follow the guidance set out by Public Health England, and that sets out a certain level of protection. Certainly in some areas, particularly, say, for example, if we're going to visit patients in their homes where the risk is higher, because you can imagine a patient coughing and sputtering a whole family, especially if it's a poorly ventilated home, a small area, we will take our own additional precautions to protect ourselves. There are also, different things that you can do. So, for example, CPR, chest compressions. If a patient were to collapse, you need a certain level of PPE, which we might not always have in all situations. So that has affected how we can operate and what we can do. And so we've had to change certain elements, like making sure we have defibrillators everywhere should that situation arise. So and actually, we have to use a certain level with all patients, because there are some patients who are shedding the virus who don't have symptoms. We almost have to treat all patients as if they're infected. So if they've got clear and obvious symptoms, they're seen in our hub. But if they don't, if they're just seen in our routine green spots and in general practice, we will still maintain a certain level of PPE when seeing them, because there is still that risk.
I see. And PPE is only one challenge that we are facing during this pandemic, among a lot of challenges. So Aula, you as an infectious disease specialist are in the middle of the storm, in the middle of the pandemic. What do you do to keep going through this pandemic? Can you talk a little bit about the practices that you have been doing to take care of yourself so you could be able to take care of other people?
So that's an interesting question. I have to say, when I reflect about this, what I would say is the humanitarian work that I have done before, particularly with SAMS, but also in volunteering for the Ebola response, for example, and working with refugees in Greece, there's a certain shift in mindset. So for us, it was late February, early March, when we were starting to see suspected cases. So we didn't have confirmed cases till we got to March. And with the pandemic, you realize that this is a marathon and not a sprint. And that changes the way, for example, I practice medicine. I know that we need to keep an eye on the kind of our long-term goal. This is not something that's going to go away within weeks. It's going to be months, if not years, before we definitely have a handle on this virus. And then, of course, it's all the things that we advocate for our patients. It's making sure you exercise well, switch off. And like you were saying earlier about the infodemic, it's really important for us not to overwhelm ourselves with very large amounts of information just about SARS-CoV. I enjoy reading about other infectious diseases, but of course doing things that aren't medical at all. And then I'm very fortunate, so I've got fantastic family, friends and colleagues where we are able to support each other. And really is that I feel, perhaps because of the work I've done with SAMS, feel able to support some of my colleagues. So for them, this might be the first time they're dealing with a crisis such as this, where they're dealing with low resources, uncertainty, either too little or too much information. And I think what keeps me going also is being able to support my colleagues. And I think the last thing that's really, really important is I have been hugely privileged to work with a large number of excellent colleagues in our healthcare system. And I've seen just how able everyone is to step up and work selflessly to make sure that we look after our patients.
Yeah, I mean, it's this pandemic, as much as it put all of us at homes, but it really got us in some way closer to each other. Or can you share a success story or a story that really stuck in your mind that happened during this pandemic, a happy story that you can tell us?
I think there's been many. I've just seen how quickly and compassionately my colleagues have stepped up. But my favourite story really is one of my first patients, and I'm not going to give too many details, but he was an older patient, not much in the way of comorbidities, but I think it stuck with me because he's as old as my father. And he was one of my first patients to deteriorate quite rapidly in March, when we were starting to see cases in our hospital. And he was intubated. He had a very rocky and stormy course, and then he was extubated and he went home. So for me, that really is a success story, because it's very easy to look at the figures, and it can be very easy to be pessimistic. Mortality when you get to ITU is more than 50%, but actually these are success stories, and he was able to go home to his wife and family.
Well, I'm glad he was able to go back to his family, and thank you for sharing this story with us. So, Michael, we had a story from the UK. Can you share a story from the US with us?
We actually did, in my particular clinic, we had one employee that tested positive, and it was after their spouse and mother-in-law were symptomatic and got tested. They came back as positive. And so then I had the conundrum, like, what do I do about the children? Because now there's actually the isolation, quarantine measures that we have to implement. And so then, this particular employee who was asymptomatic went and got their children, brought them here to the clinic. I was able to test both of the children in the car, obviously in full PPE. And then it was just a conundrum, because one child came back as COVID positive, even though they were asymptomatic, and the other child came back as COVID negative, even though they were asymptomatic. And then this negative test was confirmed on a send-out test that I got back yesterday. And so now it just kind of made things a bit difficult in the recommendations that I would give to them. I did let them know that in the end, it's probably going to be the public health department that's going to be guiding you on this. But what I said was, this particular child now needs to remain in isolation in their bedroom away from everybody. So it was maybe a bit odd in how it was a complete flip mode situation. In that everybody else in the house was documented as having been positive for COVID-19. There's one person that was just documented as negative, but instead it was the negative person that now needed to be isolated. So we're following their case just because obviously they work here. So far, I think everything seems to be stable as far as that goes.
Yes, certainly having a patient with COVID-19 changes the dynamic of the family. So Afsana, what message do you have to families of patients of COVID-19?
I think it's clearly a very difficult time. It's not just for the families of patients with COVID-19, but I think that in a way can be a little bit easier because you know what to do in terms of the isolation and keeping them separate and obviously worrying about them, but you have the access to the healthcare. As Aula said, we're very privileged in this country. I think for me, where we've seen a lot of confusion, a lot of anxiety is for the high risk people. So what we call in the UK, the shielded group of patients. So these are patients who have a certain set of conditions, diseases that puts them at higher risk, lung diseases, cancers, or they're taking medication like immune modulating medication or receiving cancer treatments that puts them at high risk. In the UK, the government has deemed that these people should be completely protected from society for 3 months. And they are a wide range of ages. They are from, teenagers through to the elderly, depending on what their health problems are. And mentally, it's a really difficult thing to do. They can't see certain members of their family. They can't go out, even though all of us can't go out, but even for the daily walks. And it's a really, and also they don't really have a get out plan until we have a vaccine, which Aula said is well over a year away. Even going out for the rest of us, yes, there's a risk and we can protect ourselves. For them, the risk is much, much higher. And I think for that group, this is where society is really important. Communities are really important in coming together and protecting these members of society really, really carefully. And I think for us in primary care, that's where a lot of the fear and concern and worry has been, and where we're trying to put a lot more of our energies. It's been amazing. We've seen community groups come together, forming WhatsApp groups to deliver food to these people. The government does too, to protect them where possible. I mean, I have family members who are shielded and they just got a text message from the government yesterday saying, find someone else to put your bins out. Don't do it yourself. So I got a text saying, right, your job now is to put my bins out. And it's things like that. But it's how can we all come together? And as you say, we're further apart from each other than we ever were, but hopefully we're closer in some respects as well. And so I guess my message is mainly to those people and the protection for them and their families to support them as much as possible.
What role do you think SAMS can play in promoting cooperation or treating COVID-19 in areas that have less resources? Aula, can you talk a little bit about it?
Yes, so SAMS, as always, has been a leader in the humanitarian field. So very quickly after the pandemic was really taking a hold in the US and Europe, SAMS was very aware that we need to be very vigilant about what's happening inside of Syria. And so very quickly they formed a group of SAMS experts to be able to respond and support our colleagues who are working inside Syria, particularly in SAMS facilities in northwest Syria. And this formed a very important role. So it was a lot of information sharing, and it's important to note that that's back and forth. And also the opportunity for some of our colleagues who are working in Turkey and Syria to be able to access some of the experiences that we've had in the UK and in the US in terms of PPE, case management, how you might set up a clinic, and also benefit from some of the early experiences and the early guidance that was being released. And it's really important to highlight what's happening in northwest Syria. So this is an area, and 948,000 have been displaced just between December 2019 and March 2020 after the latest wave of violence. And in fact, the violence has continued. So whatever we face in our settings in the UK, in the US and in Europe, all of us dread to think what could happen should cases be identified in northwest Syria, because there are so many complications in terms of the density of the population, access to healthcare for the population, the availability of inpatient beds, but also the availability of ventilators for those 5% or so of patients who are deteriorate and need ventilation. So there's a lot of factors that are at play in northwest Syria for a population who are already traumatized by many years of conflict. And what's been really positive is to see my colleagues within SAMS in each of their specialties, so cardiologists, psychiatry specialists, other mental health specialists, really step up to support our colleagues who are working in the field and who are arguably working in some of the most challenging and difficult circumstances already.
Thank you. Afsana, do you have anything to add to this?
Not as much in the sense of my own personal experience in that area, but it's very heartening to hear what Aula said and how she has described the work going on there. I think, referring back to one of Aula's earlier points, colleagues both in the UK and the US are experiencing things that we've only experienced working in those types of fields, and they're learning very, very quickly. We can only hope that they take this and they take some of their learning after all of this and give more to those kinds of areas, whether it's, you know, in Syria or the surrounding areas, refugee camps all around the world, or conflict areas, to use these newfound skills in that way.
Thank you, Afsana. And, you know, as physicians, you know, our duties have always been to take care of patients, but this time what is different is that we are on the spotlight way much more than before. And I can't thank you enough, all of you, for all what you do for caring for patients, COVID or non-COVID patients, and also for being with me here today. And thank you for providing us with this updated information. It was very nice chatting to you, and I hope you stay safe and you stay well.
Thank you.
Thank you very much.
Rebecca.